welcome to this Care Talk Business podcast. My name is Morten Mathiesen and I'm one of the co-founders of Sekoia, delivering a care planning platform for the care sector in the UK and in Scandinavia. Joining me today will be Adam Hutchison. I know Adam as the Managing Director of Belmont Healthcare, a trustee of the Care Workers charity, and as a board member of the Care Association Alliance. But Adam is truly, and most importantly, a real voice for the care sector. And this is what I want to talk to him about today.
We're on a podcast, Adam.
I know. Welcome. Or is it
Well,
you
welcome.
welcoming me?
Well, it's both ways, I guess.
Good to see you.
Likewise. How have you been?
Yeah, good. Yeah, can't complain. It's been tough for many people in the sector, including yourselves, suppliers, operators, individuals, team members. It's been a challenging time. So it's, we record this at the start of April. I think it's nice to feel like we're, the sun has been shining. Easter has passed us by, and we're moving into a new time. I think onwards and upwards. Yeah,
I can definitely feel you on that one. It's been, for Sekoia's perspective, a crazy year. You and I were doing some business at the start of COVID. I mean, we were basically rolling out care planning to Belmont, and then all of this happened, and we've been sort of in a middle position since then. And I think that's been our story quite a lot, really, that some providers were leaning in and really wanting actively to go ahead. And then this happened and others came, and it's been obviously independent stories and what could you cope with as a business. And I think for us, it's been a good year. Actually, we've learned a lot about implementation. We've gone from being on site, holding hands on all implementations, to now doing everything virtually, at least for this time or this period at least. We've also seen the need for doing things more quick starts because people were obviously allocating resources to a lot of other things, naturally. So I think we've learned a lot. Have you learned a lot?
Well, I mean, as an organisation, we're Belmont Healthcare Group is a small operator. We are 5 homes, employed in and around sort of 200 people. As all operators would say, it was the year that nobody wanted and nobody will forget. And it still continues because it's going to leave a lasting legacy with us in our practices, our processes, our approach. But I think you just have to be very fleet of foot and dynamic and think about what you're going to be doing. I mean, that's what we've had to do. We've had, I don't particularly want to go into on these all the horrendous issues that we faced with sort of death and sickness and unhappiness and emotion that everybody went through, especially the teams in at the front line. I could wax lyrical about all of that for hours and hours and hours, but there's a negativity associated to that. So I think it's about looking at what things moved us forward, and I think hopefully we'll talk about a bit that today, in terms of technology certainly being a primary focus of our business and what we've done in terms of a group to shift us forward. But the key one has been shifting our focus of what we do. I'll be honest with you, we essentially changed our business model in 4 months. Our business model as an organisation, Belmont Healthcare, what we did, we operated care homes of sort of medium to high need dementia, but in the residential space, not nursing. We're very focused on a sort of 60-40 private mix to local authority or CCG mix. So, more 60% private. And what we did, we used to acquire failing care homes. So care homes that had an inadequate rating or an RI, or predominantly inadequate. Our last 2 acquisitions were 5 inadequates, for example, that needed some work, can renovate, can do them up, and then we add value and recreate. That's basically the business model. In my opinion, that business model doesn't exist anymore, because the choice that people need to make about going into a care home has changed. let's be honest. If you are a grandchild or a child of a individual that is requiring care, you are going to be making a different decision about whether that person's going to go into a care home due to the press media narrative that we have got during this process. Social care hasn't been, it took us, 3 months to get a clap alongside the NHS, and now we've been forgotten again. So my issue is around that, is if you're going to make a decision about going into care, it's now going to have an added no. You had lots of no's before, don't want to go into a care home, but now you've got more reasons not to do that. And we also still have an element of the UK that's furloughed or working from home, which means they can support their families themselves more than they used to be able to. So I think that window for operators like ourselves has reduced. I think you're still going to see that market for your high-end, exclusive, care home groups, people who are choosing to go into a collective community of care. But I think in our market, you're sort of 35 to 55 bed care homes that in a more contemporary setting, I think it's going to be more challenging. So what we did is in December, when we had our worst COVID experiences across the group, and we lost, for nearly 20% of our occupancy in a month, we very quickly, myself and our operations director, decided to change what we did. So we're now much more focused on rehabilitation, working with NHS CCGs, supporting people out of hospital. We've changed our management information to say, rather than we need to have over 60% privates, we are looking for over 60% of a fee range, because we have to have a certain fee range. It's a business. We have to have a certain fee range to survive, and a local authority fee range doesn't work. So what we've decided to do is flip the metric. So rather than looking at private versus local authority, we're now looking at over a certain fee range, and it doesn't matter who funds them. I think now we're at nearly 85% non-private.
Yeah, wow.
Now, already in the space of 4 months, but we're getting higher fees than we were getting from privates, because we've won contracts with local authorities for rehabilitation, complex dementia, all that sort of thing. And we did that very quickly. And then what we did, which, this is quite timely, so we'll see this get out on our social, and we're doing a big launch around it this week and next week. We've launched what's called Belmont at Home, which is essentially our domiciliary care service or community care service, but it's very much focused on being the continuity arm of care with our business. So we're doing home care, but it's home care in a way that is, it's minimum hour visits. It's much more about rehab. It's much more about support and help services. So, for example, there's no tunics, there's no logoed cars. That's why it hasn't got care in the name. It's Belmont at Home. It's very focused on individuals in their own home that maybe are having that early setting of care. But the idea is that they will then, as we're starting to deal with people earlier in their care journey. So we're down here. And then when they may need to come into a care home for some respite or some rehabilitation or some daycare, we've got care homes that they can do that. And we're doing this circle. And I've talked about it for years, I'll be honest. I've never really done it. I've kind of been quite slow to get to it. But COVID has gone, no, you've got to do it now. So what we've done is we've created another business stream, but changed the model. So that's what essentially has happened for us. We've had to become a different business. We're no longer doing what I did last year.
Yeah. Well, kudos. I know how tough this period has been for you, for Belmont, for a lot of providers as yourselves, as you're saying. Right now we're part of, or at least just exploring a partnership with Surrey Care Association for something that Simon Wally is calling the virtual care home. And it sounds a lot like something you're actually already putting a name to, Belmont at Home, where you're
that's essentially what the plan is because we've got like these different tiers, and one of the tiers is using technology. So we use a product called Ali, which is a Wi-Fi acoustic monitoring. So if you're of a certain need level and you're at home, what we do is we put that into the home for free as part of the subscription with us, because it's a subscription model of care. So you don't pay for the hours in arrears. You buy it as a subscription model, because everyone's used to subscription models now. So it's quite unique. in that sense. And then people are paying for that subscription. If you have the higher band of subscription, we basically install a broadband in your home, because our research tells us that 75% of people of an age range don't have broadband.
Don't have it. No.
So we install the broadband and the phone line if they don't have one, which they normally do, but we put the broadband. So we own the contract for the broadband. So it's no headache for them. They don't have to worry about cancelling it if anything happens. We take that on. So we're almost a commission of broadband. Yeah. We put that in, then we connect the Alley device, but the Alley device is linked to either a local care home or our Belmont at Home night team. And then what happens is, if they get a trigger, we go out and see them. And the idea is that we can reduce the amount of 999 calls that they make, because, and also it adds a level of comfort to the family that they know that there is an acoustic service that's monitoring that individual while they sleep. So we can monitor them for a certain hours, a period, a range of sleep. And then the long-term plan is that then we can link that into a number of other systems. At the moment, it's siloed on its own as an app. But we use it in our homes already. So it's kind of like we introduced that product during COVID. And the only reason we did that is because how are we able to isolate residents and not have to keep going in? So right in the early stages of COVID, we had to re-energize our funding and go, right, we need to focus on something. So we actually used our infection control grant to pay for the installation rollout of Alley in 2 of our homes and the Wi-Fi networks. So what that meant is that we could isolate people and monitor without having to keep the staff going in and out. And this was before, this was really early days. This is before we had the kind of more infection control protocols that we have now. And also your staff teams have become more comfortable with it, because you got to think, right at the very beginning, it was like everybody was freaked out about what was going on. You did, as much as you were putting as many protective associations in place, you still couldn't, staff were still scared of going in. People have forgotten that we were expecting people on, relatively low pay to go frontline, do something, and were scared. There was no difference to them going in a care home as it was in hospitals. Let's not forget that. Those, you're talking a year ago, like April, May of last year. I can't believe it was a year ago. It's frightening, isn't it?
It's crazy.
It's absolutely bonkers, isn't it, that we're talking about it a year ago? But yeah, that was kind of what Belmont at Home is. And like I say, it's quite apt we talk about this. It's not officially launched because we're waiting for our CQC registration on 2 locations, one in the West Midlands and one for Kent and East Sussex. So we're running two offices of it. But we've been building the platform and getting everything set up and working with the various things that we need to have in place. And then after that, so I'm really interested to hear more about the virtual care home that you're working on. So how's that working with you and Sekoia?
Yeah, well, actually, it's funny because at the same time, I'm originally Danish and working obviously throughout Scandinavia and the UK, and we were approached by a Danish municipality about a year back, and they had this vision of something they called the pre-care home setting, which is very much what you're describing. Basically, you are enrolled in a care home and you belong to a certain care home, but you just don't live there. You live at home, but via various technologies and obviously an on-call team. You're not really at home in terms of domiciliary home care. But you are part of the care home, but you're just monitored and surveyed via technology. And I think very much when Simon then from Surrey Care Association approached us and talked about the virtual care home, a lot of resemblances, and then really cool to hear you actually just going ahead and doing some of this stuff. But you're saying today that basically it's left for the bigger providers, it's left for the luxury providers and for the bigger groups, and then villages, or what are you saying? How is
I think if somebody is making a decision to go into a care home and doesn't have major physical or cognitive disabilities, i.e. they don't sit in that sort of high needs dementia, Huntington's, Parkinson's type realm, and somebody is more making their own choice to do it and be in that environment, I just feel that why would they make a decision to go in a care home of a particular style? I think it's going to be much more about if you can afford to go into care and that was your plan to be in a sort of luxury village environment, then I just think that market is going to be smaller. And there will be people out there who disagree with me, Morten, for sure. But that's my opinion. I just think that, you're talking about a market that pays over £1,200 a week for their care. I just don't think that decision is going to be made as easily as it was before. And I think the choice is going to be more, if you're in that affordability range, you will want to go to the sort of very high-end, purpose-built type stock of care homes, because you're looking for something from it. And then I think that people just need to reposition themselves into the right place. I just think that there is a lot. We've lost a lot of people in this time as well. Let's not forget, of that age range. What is it? Over 95% is essentially the market in which our care market was focused on delivering in, the elderly, older person's market. We're affected severely by the pandemic, and will continue to be so if there's any other variants out there. Evidence is clear that, I think the average age of death from COVID is actually higher than the average death age in the UK normally. Yeah. So if you take that, just think about that for a moment. That means it's really focused on that set of society. Therefore, I just think that we have to be careful with what's happening out there and focus on the right things. And the other argument for it is, I've always come into this sector because while I love it, but I also felt that there's lots of things that don't work.
Yeah.
And I think what this has proved is it still doesn't work. And the biggest thing is we've just spent for 15 months telling the country, or the government have been telling the country, to protect the NHS, right? Yeah, we have got to protect the NHS. But let's think about the NHS for a moment. This is a fact, right? In 1989, there was over 250,000 NHS beds in the UK, right? And a lower population in England, sorry, not UK, in England, and a lower population across 168 hospitals. Today, there's 114,000 beds across a larger population.
Yeah. So
just have a think about that, right? So we've got 50% less beds and about 12% more population. Okay. And there's 56.5 million people that live in England for 114,000 beds. So it's not rocket science to say, if you have a bit of a bad, this has been awful, but if you only have a bad flu year, the NHS can't support it. So we're never going to fix that. The way you fix it is we need to create a system that says social care does this and the NHS does that. So we know that acute emergency care goes here. Supportive rehab is over here. And that's where the market needs to grow. So there's so much space for us to have multiple operators, multiple providers with multiple services. But we have the public and the press need to understand that, the health need to understand. Adult social care is there to deliver this. Remember, right now, there's 450,000 beds. So there's more than treble the amount of beds in social care than there is in health in England, let alone Scotland and Wales. So you think of, there's a missing link there. We've got occupancy issues across the sector. The NHS is oversubscribed. Our sector could pretty much accommodate for a lot of ailments of what's been done in hospital if we focus on training, development, improved technologies, things like CHAPS, advanced practitioner training for our care teams, which then pushes their development and their experience up, which therefore pushes their wages up, which means they're being rewarded more and paid more, which everyone says they're not paid enough. So the system can fix itself if we allow it to. But that's a much bigger picture that we need to all work together as suppliers like yourselves, new technologies, operators like me, working in environments like this, in podcasts where we get the opportunity to say what we want, and we get to go, right, this is how the system needs to work. We need to work towards telling people, the public and the government, that the NHS's job is X and social care's job is Y, and they both fit in the same role at the same time. But it's just when the individual moves from one to the other needs to be repaired, because we don't know that.
No.
And when the person is first prescribed any sort of health intervention, it's knowing very clearly which bucket or which process that person needs to go into, because it could be that they could go working what you've talked about with improved technologies in the home, virtual care homes. What a cool idea. Obviously we've started doing something, but we didn't call it that, and I wish I had. Was that we are preventing that person using the NHS service, which means that's more available beds for people that need it. It's not rocket science, but for some reason I sit here sometimes going, we could have told you that was going to happen in May. When we were spending millions of pounds on e-tail to help out, why weren't we focusing on fixing the social care NHS? And then this wave that we just had, we might not have had, because those people could have come into social care. Why didn't we think about that? Because we've got empty beds. Hello, everyone in a care home's got empty, and we could probably accommodate for 20% of the people that are in hospital. I'm going off on one now, but that's kind of such an important piece that we need to get across in a messaging, but it's just not happening.
But you're saying that, if I understand you correctly, we need to all gather around this issue and fix it together. But don't you think that the one instrument that can help this really kickstart is a different vision for and a different funding of social care? Or?
Yes, I think you absolutely. It does, but
we can't wait for it.
I'm going to say something controversial now.
That's why I brought you in here.
The problem is that we're always asking for more money. That's the wrong way. We should be asking for the money that's already there to be spent in the right way.
Yeah.
Because I think that there is plenty of money in the system, and that's been proved by COVID, because we've miraculously found 300 billion to fix a pandemic, but we couldn't do that to fix the health and social care 5 years ago. There was never enough money, but we managed to find, X amount of billions for furlough, which, is we couldn't even access, because why would we furlough anybody? So I think what really people need to sit down and go, right, all of this money that's being spent here needs to be spent here in this way. And I think that would make a huge difference, because we're pumping money into a service such as the NHS, which is amazing. And I clap for it, and I was there, and I appreciate it. But a lot of that money that's been spent in that way could be reformed to be spent as a joint approach, because look, we're taking people out of hospital at the moment, and I'm not afraid to say it. We're taking people out of hospital every day for over £1,000 a week into a care home, which is more than we get privately in some of our care homes, and we are saving the NHS money in doing that, because it costs them more than that to have that person in hospital, but we can meet their needs in a care home setting. So it's getting rid of the stigma of what a care home is, getting rid of a stigma of what our sector is, which is more a campaign, a messaging, and then retraining our teams, upskilling our teams to be closer to those services. And this builds into recruitment, because, which is, I'm sure, is on the list of problems that everyone talks about, is how can we fix the recruitment problem? Well, we just make our sector more interesting for people to come to. I've always said, if you're a doctor and you work in a hospital, right? Surely when you're training, wouldn't it be great if part of your curriculum is you have to go and work in a nursing home for 6 months of your doctors or your training to become a doctor or a surgeon or a nurse? Because then when you go into the health service, you won't have such a derogatory thought process about what they do, because you've had an experience of what care teams do, which is an amazing, hardworking, above and beyond job, amazing people, not respected and not paid enough. And I'm part of that problem, because I don't have the ability to be able to fund high wages, because we don't have the high incomes to be able to do that. So there has to be a balancing act. You have to, people forget that over 60% of our turnover as a care business is just on payroll. That's just like, name a business in the UK that does that. It just doesn't sit at that level. It doesn't sit at that. So it's a total reform of the way the money is spent. Not that we need more money, because I think there's plenty of money in the system. I really do. It's just wasted. And that's my controversial statement.
No, I don't think it's controversial, especially as you're just telling us how you're actually doing stuff. Meanwhile, you're not just waiting for a refurbishment or how that money is spent differently. You're actually doing stuff. And I think that's part of the solution. As you also said before, that you and I and a lot of other people go ahead and show others that are waiting or just sitting on their hands or are worried or thinking about how to not survive, that there is actually a different way forward. I'm really liking what you're saying here. It's
what have you found because obviously you're the largest provider in Scandinavia. What have you found in Scandinavia in terms of how I suppose what have you seen in terms of what's happened in the similar environments? Is it differed much to us? And B is, because you're so present as a technology provider, how have you seen the use of your technology or technologies in general have an impact over there different to here? If that is that?
Yeah, no, it makes great sense. I think first of all, the Scandinavian societies are quite developed when it comes to having a national infrastructure for care journals, care systems, and all of that stuff. So where Sekoia is more of a full range digital care planning solution for the likes of Belmont, then here in Scandinavia, we are an add-on to a more nationalized infrastructure. So we have to play with what's also, I think, perhaps coming national clouds for various integrated services in the UK.
That's interesting.
Which is, again, forwarding how you're able to, as a smaller supplier, we're only 25 people in Sekoia, but you're actually able to lock yourself onto a bigger scheme of things and still be able to provide care providers with COVID-19 symptom checkers based on NHS best practice, which is one of the things that we've done, or simply, which I think maybe now I'm going to say something controversial, or simply also allow care providers themselves, actually someone like you, to say, well, I am diversifying my service now. So if I have a care planning system where I'm locked down to a residential way of doing things, I can't really use this in my rehab services because it doesn't have all the assessment types or the forms, etc. Where we've always in Sekoia taken a more flexible or bespoke trail, and we're saying we're going to have that solution that you would have to request from others to build, but you're able to, with our assistance, of course, you can get that, and you get that for free, and you can get it immediately in Sekoia. So you can diversify, you can have mental health and nursing in that same solution, which I think is something that the market in general, for care planning at least, is struggling with. Because a lot of the good solutions that are out there are based on either home care alone or residential alone. And as you're saying, you have to diversify. You have to think of new ways of also supplying stuff to the market that the market is in need of. So there is definitely something there that we've been providing throughout this period, and we've been trying to find out how to get that to the market itself also. Then there's also a level of service where I think that sometimes if there's something that I could say, I think we've underachieved as suppliers in general, is that we've just provided a technology solution, and we've sort of left it for providers, or sometimes, I mean, frontline staff themselves to find out how they want to use it. And then they get to use only 5% of the solutions because those are the most accessible ones, or whatever it is, the reason is for not using the full suite. Where we say, as you said before, it's a subscription, and you have access to our experts, how to use it, how to get the full value out of it. And it all comes with the subscription. You don't have to pay anything extra. There's no hidden fees. There's nothing of that, because that's our pledge to the market also, to providers, that you're not bound by Sekoia. There's no vendor login. You can leave when you want, and you get your data with you if you don't want to work with us, at least. That's not always how it's been. And I think that's also part of why suppliers, for some years at least, and I think there's definitely a bettering of that now, but have been like some providers or have thought that their suppliers were a bit too hard to sell, all in all. Am I wrong?
No, I'm nodding along. I can certainly agree with you on that. I mean, I'm a massive believer, and if anybody puts a contract in front of me anymore for a length of time, I will never sign it.
Yeah,
because that tells me that they're not interested in continually keeping themselves honest. Because if they're going to do a good job, you shouldn't need a contract to lock your customer in. So I think we've recently had this with our e-learning provider, We've just because we just don't like it, and it's not fit for purpose for us. And we moved over to e-learning right at the start of the pandemic, just because our training team couldn't move around the homes. So we went right e-learning and didn't even think about it. Ended up, it's like a 3-year contract. It is what it is. We're stuck in it. But I'm actually still moving to a new provider and just paying that off, because it's that bad, that it's that clunky, that the new one is. And we talked to them, we walked through it. We said, we wanted to do this. Yeah, that's fine. We wanted to do this. Yeah, that's fine. Wanted to do that. Yeah, we could do it. But the biggest thing that we found coming into this technology thing is just around devices. It's because for me, I spend my life on a laptop, because everything I do is on my laptop. You normally got 2 or 3 screens up. I'm in my office at the moment. I've got one either side of me. I'm always kind of like, but that's what I'm used to. And I use my phone, but I don't use it as much. I use it for certain things, but I'm not like. But for things like your services and training and e-learning, a lot of our teams want to do more of their stuff at home. And you forget that actually all people have really got is either a big phone or a tablet. And certain things are just terrible. They're not designed to be on mobile friendly. And our e-learning platform was exactly that. They literally couldn't use it. They could not use it on the phone, because it was like, well, we can't do it because it's too small and we have to keep opening it. You can't actually follow it because it wasn't designed for those systems. And actually that's caused us more headache, because actually people can't therefore do the training in the environments that they want to do them.
I think that's totally pinpointing, without mentioning any names, but that is pinpointing what I think is also happening right now. In general, the consumerization of technologies in the care sector, where people, frontline staff, are asking their providers to bring us some new technologies, but let them be mobile first, let them be responsive, let them be what our phones are as we know them, because then we're comfortable with them. And I think that's a big shift we're going, at least in care planning, we're seeing that you're going from more computerized or first version of electronic systems into real digital systems, which is mobile first and all of that stuff. So that's a positive change, I think. And also, even just on the cost side, if you look at it, I think when the first providers, and that's of course 20 years back, started to go digital with their care recordings, it was a huge, huge cost on them. And it was actually more expensive than paper. But today we've just, we haven't done the study, but one of the providers that we support have done a study, and they used to print 30,000 sheets of paper per month. This is a nursing home. It's about 1,000 pieces of paper for the care documentation per resident. And that cost them around £1,000 per month to have that running with cartridges. Of course,
yeah.
Everything.
You forget that cost.
But they pay us 300.
The paper costs,
and I don't mind saying that. They pay us 300. So it's a massive cost reduction going digital, but people were thinking that it was going to be more expensive. But then you get the efficiency gains on top of that, where you're no longer spending 1.5 hours end of shift doing your paper records. So there is actually also a trend of consumerization where you're looking at it and saying, this is a no-brainer for us now, we're just doing it. So luckily we get a good uptake at the moment. But it's also because of what I said before, we are supporting the providers. It is a start, of course, but we're definitely seeing that with a bespoke system, you can then also have it catered to your different types of services, and then you're up and running. And then what it matters for someone like you or your operations manager to have that data and say, well, I want to track falls in one home or for this particular person or throughout our whole service, and I want to see it on a 30-day or a last year or whatever, and I can go in and follow that. Or someone we were visiting the other day, they were saying that they've been challenged on something and they had to go back in their paper records. I think it's 4 years, or you probably know, but she was then, as the manager of this particular service, going back 4 years to find documentation of what they've done in relation to a particular individual. But that's crazy. She must have been looking various places for those records, but she could have clicked her way through it and gotten a report and some of that stuff, which I think is another thing you can have for governance, for compliance, and all of that good stuff.
You're right, and it certainly ticks a number of boxes in that sort of sense, and it just aids people, and people want that now.
Yeah,
You know, even when you go back to recruitment, I always kind of say that if you're looking to encourage a younger generation to come into the sector, they also want things to be cool, because that's just what it is. You've got to have cool things to be working on, and when you implement things like that, you do see an excitement from people. It's like, oh, we're not having to write. We've got a system that we can use, and it actually encourages them to get involved with it. The teams to get involved with it. I think one of the issues with the teams is sometimes around if the system is just a bit too complex. Sometimes, but just because it's nothing to do with anything other than people have got so much to do. You want operational efficiency immediately, and that's what the world that we live in is used to. Isn't it? You know, people aren't used to, Facebook, Instagram. It's not clunky. It's simple. You're in, and you can use it, and that has to be part of the journey. It can't be something that takes forever.
It was actually an issue that we were facing a bit because of what I was saying about being bespoke. You can actually tailor a lot of stuff, but it also means that you need to build it. But we were then seeing some homes say, "Why can't we just use what you have in your demo?" Well, okay. So we've built some starter kits. So if you're residential, if you're a rehab, or if you're learning disabilities, then we've said, all right, this is a good starter kit for you. Let's do adaptation instead of doing full implementation of your own system. And then where you want it to be bespoke and personalized to residents, this is where you then put the vast majority of your efforts. So we've taken the implementation time down throughout COVID, just by the learnings that we've had, which is, I think, really cool. But there is still that same element of being able to be bespoke, which I think is necessary, especially if you look at the way the market is developing, as you've described it. Another thing,
definitely. Yeah, far on.
I'm part of a group, or a club actually, which is called Social Care Disruptors Club, organized by the fabulous Jane Brightman from Institute of Health and Social Care Management. And one of the subgroups is called Issues that Care Providers Face. And I have a long list here with me, but I was wondering if you would tap in and see if you've got something that's not on our 10-point list here. What's the biggest issues right now, Adam? You've just described one of them before, actually.
Biggest issues.
I can name a few.
Yeah, I can name quite a lot, but I'm just trying to think of what I would kind of pinpoint as the biggest.
Yeah,
I mean, essentially, we operate businesses. I know people don't like us saying that, but we do. They're not. There's not for profits out there, but they're still businesses. We're essentially not government. We part government funded in terms of the people that we look after, but essentially we're businesses. And the key is that businesses derive and operate from revenues, and revenues comes from income paying customers. So if you take it down to its minutiae, it's about how do we glean and encourage more customers to pass through the system. And the biggest one for me around that is this whole thing about sector as a sector's sort of campaigning of what we're seen as. I've talked about this a number of times. I think I've done it on a previous podcast that I did a couple of years ago, and I said I spend 10 minutes explaining what I do for a living. When anybody who doesn't know asks me, I don't say I operate care homes, because I feel like if I say I operate care homes, I feel like the instant stigma that ascertains, down to the fact I don't even call our services care homes. They're all called lodges. So we don't call them care homes, because the idea is this fluid services that you can have between them. It's not just a care home. But I want that to end. I don't want to have to explain what. Excuse that. That was my phone going off then. That's not very good, is it? How about that?
No worries.
That has never rang. It's my office phone, but it's never rang.
The landline.
Yeah, never rings.
I love it.
No
we
idea.
have a landline, ladies and gentlemen.
Me, I have a landline in my office. The trials of Zoom. Goodness me. It's on my desk. And I moved offices about 2 weeks ago, and it's got a new number. I don't even know what it is myself, but it's just rang. So there we are.
I'll find it and call you on a weekly basis.
What was it now? Yeah. edit. It's the stigma of the sector. I would just love that people would be making better choices, and they're not like, "Ooh, care home." That's kind of. I still feel like we still have that. I still
crazy,
feel
yeah.
like, and I have to go right. So what I do is, I run a company called Belmont Healthcare, and this is what we do. We have a number of care homes, but we focus on people that do this, and we look at doing innovation. And I feel like I have to do that.
Yeah,
I don't want
that's
to
a
do that
shame,
anymore.
I
I just like to say I operate in the health and social care system. That's it.
Some fantastic care homes,
No, just I operate in the health and social care sector. That's all I want to say. And
yeah,
then
yeah.
know what it means.
I understand that, but you do really operate some fantastic lodges, care homes, and I think there's no shame.
Yeah,
to that.
I mean, we're going to try and get back to that. I'll be
Yeah.
honest with you. The last year doesn't feel like that at all.
No,
It just feels like that we've just been firefighting, and all of the good stuff that we're trying to do has kind of just gone to the wayside. And I feel pretty upset about it all, really. But there's nothing I can do about it. We've just got to. It's done now. I mean, we've lost 15 months. We've probably gone back a year or two in our growth plans, just in terms of where the business was.
Yeah.
We were in a very specific point in our business life cycle. And it was probably the worst timing of something like this. Do you know what I mean? Because we were in that position of our business life cycle. We were right at the bottom of the bell curve. So you're kind of in that sort of high growth, high resources, risk element. So we got pretty hammered, and we just got to diversify, rebuild, focus on technology, and this year start again, which is what we're doing. We're doing our April 2 of 2021 is Project Restart, as we've coined it. But yeah, that's the biggest thing on the list for me, is just how we become attractive to our customers again, and who our customers are.
It's on my list. I mean, not that it's any consolation, but it's not only your problem. It's huge, definitely. And I think it's also hard, as you say, because of the general perception of the sector, that you also say we're a business, and right now it's harder to get customers. Yeah, definitely. It's number one, if not for recruitment retention, perhaps.
Well, yeah, recruitment retention is an interesting one, because I think we've got a fantastic opportunity in recruitment at the moment, especially because we focus on our roles being very much about well-being. We're focused on the well-being of people, with activities and driving, enjoyable, fun experiences within our environments. There's a great opportunity with the hospitality sector. You've got people that have worked in events, you've got people that have worked in catering, you've got people that have worked in entertainment that are technically haven't got industries. We should be tapping into that, because that would be, which means we should be having front of house, and all of those things are great for us. There's some care providers out there that do that absolutely fantastically. I don't want to name drop too many, but there's one in particular that just does amazing work with their sort of, it's almost like, everything seems really fun, and you can see that in their video content and online content, and that's driven by, people who have come from external sectors into that. And I think that's a great opportunity. I think we've missed a boat on some of it as the hospitality starts to reopen. I think pre-Christmas, there was a great opportunity for us to focus on that. And we work with some of the guys, like we work with Wellness, for example. We used to have them coming in, and now we do their on-demand stuff. We're doing quite a lot of social content around that recently. And that's been great, because that helps people understand more about what happens in these environments. We've got to get away from this thought process that it's just, we didn't help ourselves during the pandemic, because when ITV or BBC or Sky News turned up at the care home, it was always in like the worst hit, where they were doing nothing because it was COVID. Because they couldn't, they had no activities going on. People were just isolated and sat in rooms. And that's the impression that people got. We shot ourselves in the foot, really.
And I've been to more of your homes, and I've been to perhaps hundreds of homes over the years. And to be honest, I've been to some of the best concerts. I've even seen, with the resources available, bowling going on in care homes. So many activities, as you're saying. And we're both part of championing social care.
Yes.
And you're part
ambassadors.
Ambassadors. And I think one of our jobs doing that is obviously to tell that story and make that heard. And I think, Rebecca and everyone there is doing a fantastic job to get that angle out. But you're also part of the Care Workers charity. How's that year been?
In a way, fantastic, because we had a new executive director join us sort of not long before the pandemic started, because I was part of the interview process as a board of trustee member. Carolina just did a sterling job and used the pandemic, not used the pandemic, that's the wrong phrasing, but it enabled the growth of awareness because of the pandemics, and actually helped garner an awareness and raise an incredible amount of money, over £2.5 million for the benevolent fund that sits behind the charity. And then now we're building on that platform to address some of the wider issues around care, which is one of the things that we started doing the Care Workers Charity pre-pandemic, but again, another thing that got lost by the way. So just be trying to create more accessibility rather than it just being about benevolent fund. We're looking at creating sort of well-being solutions, trying to really engage care teams in to look after themselves more. We do it in our homes, for example. We use we operate a wellness program in our school. So we try and encourage like healthy eating and eating healthily and drinking more water, and trying to encourage people to exercise. And we have like this it launches at the end of April, part of our Project Restart. We're introducing something called Try Wellness, which is like it's an online portal, and you can access it, and it's for companies. A lot of the NHS use it as well, and it has sort of like meditation, and it has sort of like mental health videos. It has doctors who you can access for mental health well-being, but it also has, basically, it's like a corporate Joe Wicks is the best way that I could describe it, because I absolutely love Joe Wicks. I think the guy's an absolute genius. But it's like that. They've got like cooking, they've got videos for like exercise and how to look after your back. They've got like how to look after your knees, how to be structured with your diet, how to and it's basically like an online program, and it comes with like credits and things like that. So you can like reward the company's rewarding their staff members for looking after their own mental health and well-being. So it's quite clever. So
stuff like that.
We're looking at trying to, we're introducing that as a business, and we're looking to try and introduce it into the sector as more widely. But it's a separate business. It's nothing to do with myself. It's just that we just have started exploring it.
I really like the idea. I mean, as a young person looking at the care sector, wouldn't you want to go in somewhere where you were taking that seriously, that there's actually a program for your well-being and for your development and everything, and you can take it more or less towards some physical elements or health or mental health, and you can build it yourself? I think that's sounds fantastic. I've noted.
Which is a key thing. I think we talked about recruitment before being on that list. I actually don't think recruitment is as important as retention. Because you've got so many people that are going to we had a retention problem before. Now we're going to have people that just go, I don't want to do this anymore. I've just had enough. I'm burnt out. So we have to think of all of these things that we can do to encourage people to stay, and that means we have to do more for them. I mean, we've been doing, because I just don't think we do enough around bereavement. I never did think we did, and we actually engage with something called a soul midwife. So we have like a soul. So she's basically, it's called a soul midwife, but it's essentially around this supportive element for bereavement. So we do like these workshops. Obviously, they're via Zoom, where people who maybe have had issues with COVID, or when residents they've known well have passed away, and we get them to come together as a group, and they talk with this sort of facilitator, and it helps them sort of like deal with the challenges of bereavement. So it might sound a bit for some people, but we just want to try and do more than just sticking a poster on a wall saying there's a phone number there to ring. I don't think that's enough.
No, I totally follow you. I think it's part of that whole package that we as a sector perhaps need to come together and realize that this workforce, it's the only workforce there is, and getting new people to work in the sector.
Well, the only way you're going to get a new person to be working in the sector is if somebody who already works in the sector is at Sainsbury's, or is at the pub when we can finally go, or waiting in line at the school and talking about their enjoyable experience at the job that they do. That's the real recruitment retention. Is how that's the way you sell it. We create a sector that goes, yes, I want to do that.
Yes,
I'm in. And that's what we've got to do. We've all got to come together as part of Champion Social Care, care worker charity, providers. It's not about the people who are already in it, like you and I. Like, these podcasts and things are amazing, but 95% of people that read them are people that are already in the sector and believe that. It's the 5% that are outside it that we need to start watching stuff and hearing people like you and I talk about the sector in this way, because they're the ones that might go, okay. And then we need the press to then get onto that. And then we need to have the good news stories. And that's the challenging part of this, is taking this longer form content and getting more of it into the eyes, into the ears, I suppose, and on the eyes and the hands of people who we need to either come to the sector or place people in the sector, which goes back to your list from the club that you talked about. That's a big part of it. It's messaging, it's campaign, and that doesn't cost anything. It's just it's just doing it differently.
Yeah, I totally agree with you. I think that's is that good? That's a good spot to end on. I think it's a good note.
I think it might be. Yeah, I think it might be. So I've got on my high horse a bit, but hopefully it's been good talking to you.
It was. I think the horse was as high as the demands are now, so that's good.